We had a speaker yesterday, who did a lot of movie work, Randy, who did a lot. There seems to be a connection in telehealth with people. So, yes, ask me later what movie I starred in with Charlie Sheen. I grew up on the North Shore in Chicago. There are a lot of movies filmed out there. But a little background, I am Lyle Berkowitz. I am the Chief Medical Officer and EVP of Product Strategy at MDLIVE. So I was one of the folks that Randy brought in to help as we evolve the company. I'm an internist, primary care doctor by background. Have been involved in IT, EMRs, telehealth, and almost anything new in healthcare for many years. I was at Northwestern Medicine, a large academic top 10 medical center in Chicago for most of my career, but working a variety of other roles. But this one keeps me very busy. So we're going to talk about today is sort of that next step. MDLIVE is one of the larger telehealth companies in the nation, and traditionally we think about urgent care, where previous speakers said we got to get them when they're sick. But what if we didn't have to get them when they're sick? What if we could get them when they're well and just sort of want to make their health care better? That's what primary care is in many ways. It's finding, detecting things early. It's screening, education, prevention. So I sometimes bring this up as the idea that telehealth in general, and certainly now the next step as we talk about teleprimary care, sometimes people say, well, that can't be done. We'll grant you sinus infections and UTIs, but can you do more? But if done well, good technology, indistinguishable from magic. And Daniel Burnham, the architect of much of what is the new Chicago over the past 100 years, make no little plans. So let's talk about what we could do if we could think bigger and allow ourselves to say, how are we going to get to that point in the next 5 to 10 years when the majority of primary care, ambulatory care is online? What if we could do that? What would that look like? So, the way I've always looked at things, as I've been a primary care doctor for 25 years, is there's a lot of stuff that we need to do, particularly as primary care doctors. And there's only so much time we have. I mean, this is for decades. Rand put out a study many years ago that said the typical doctor, if they did everything that evidence says you're supposed to do with all of their patients, would be working 25 hours a day. Just impossible. But if we start using other technology, automation, et cetera, I don't think we have a shortage of physicians, as we all say that we do. We only have a shortage in the sense if we stick to our same system. It's like saying we have a shortage of travel agents because I can't find a travel agent all the time 24/7. We have a shortage of bank vice presidents because I can't speak to a bank vice president every time I want to go in. That's not how we do it. So the same way, we don't really have a shortage of physicians, just a shortage of using them efficiently. And if we could use HIT-empowered team-based care and EMRs, it's not enough. We have to do more and more and more in an automated way, just like every other industry has done. So we bring in telehealth. And this is a study Eric Topol wrote about from University of Rochester, suggesting by 2025, significant amount of ambulatory care will be done online. And telehealth will be a big part of that, obviously. But that also is not enough. Just taking a 15-minute office visit and putting it online for a 15-minute video visit, there's a lot of goodness in that. It helps a number of people who can't easily reach folks, but it's not scalable. And today we're going to talk about scale, because to do this right, telehealth can't simply be a video visit, or even a phone visit, et cetera. It needs to be done at scale, therefore it needs to use automation, AI, and every other modality possible to get to the point where we can scale this. Another way to look at that is the classic pyramid. Many of you have seen this. This represents our healthcare system. 5% of people who represent the sickest, but there's a whole bunch of people who are not nearly as sick and represent 50% of people represent 5 or less % of our costs. And yet, they still consume many of the resources and the physicians that we have. They use the healthcare system. And so what if we really focused on the office-based care on the really sick? And for people who are healthy and have routine issues, we put that online. And not just not just on a video, but truthfully, automated it as much as possible. Minimize the doctor, except for where the doctor is needed. Then the pyramid could look like this, because right now it's basically all red. If you want health care, you pretty much have to go into the office. MDLIVE, we'll do 1 million or so visits this year, and the other vendors will do that, but it's still scratching the surface of all the visit that needs to get done. So what if we could think like this? What if we could transform how we take care of folks just like every other industry? When was the last time you went into the bank, went to a travel agent? Same concept. So what might that look like? In fact, what if, this is a thought exercise I did a number of years ago, actually about 15 years ago, was what if we banned offices? What if there was no more primary care offices? Like, if you want to be innovative, you have to think and give yourself some constraints that push you. You don't say, oh, how do we massage things? Boom, they're gone. How do we take care of folks? 15 years ago, we actually came up with what you would now refer to as Uber and Lyft. We said, oh, there'll be ambulances that go around and they'll just come to your house, et cetera. And of course, there's a little telehealth, but where would those guys sit? But the idea is you have to push yourself harder and give yourself some major constraints to be able to think beyond a couple of years. So that's what we've been doing. How do we expand beyond just taking care of a sneeze and sniffle online? And in many ways, how do we bring the house call back? Because that's what we're doing. That's what our patients feel like. I still take calls online, and it's pretty cool to have a patient, sitting in the office, in their home, on their couch, sort of sick, and just saying, "Oh, I'm so glad you could do this. I was so sick." In fact, how many times I, as a doctor, have been told by a patient, "I'm too sick to come in," right? Really? We're like, that's too bad, then, we can't take care of you. But they're sick, and how great is it to do this? How happy are patients when we can come into their home, and maybe Randy can deliver a medication to them right away. How amazing would that be? The reason our NPS scores are so high in telehealth is because we literally delight people. They are used to calling up the doctor's office, having to wait to get in, going, how much time it takes them to go there, sitting in a room full of sick people, which they hate. Finally seeing the doctor for a couple of minutes, even if everything turns out okay, they're not delighted, they're okay with it. Meanwhile, on our end, they click a button, a doctor calls them back in 5 minutes. They're delighted. So how do we bring that to more? So what does virtual primary care look like? How do we do this? That's what everyone asks. It's like, well, you can't do that, right? How do you do that if you can't actually touch them? So one of the interesting things that you learn in healthcare is much of what we do is what many of the great sages said, and that the history is more important than anything else. A patient will always tell you what's really going on. We don't necessarily need to touch a patient to get much of the information we need. So how does this start out? Well, I set up an exam online. I take an HRA, a health risk assessment. I get sent a home blood pressure cuff, check my vitals. I see the doctor a week or two later, and I've also been told to get my labs at a local lab facility, which is basically open, every day of the week to evening hours, so it's easy for me to do. And that doctor then reviews, what do I have? I've got HRA, I've got biometrics from both their self-reported vital signs and labs, and I'm able to do a couple things for them, right? I'm able to let them know if there's anything that we found that is a warning sign. I'm able to give them lifestyle advice, diet, exercise, quit smoking, able to suggest vaccines or screening tests, able to detect if there's any abnormalities that may need further follow-up, either online or in person. But now we have done screen at scale. Most plans find that only 20-ish% of their patients actually get an annual screening exam every year. We think we can make that a lot higher. So over the course of the year, I may suggest a digital therapeutic to help them with their weight loss. We have Sophie at MDLIVE, that's our little chat bot that's checking in. on patients every month, have a follow-up appointment. So if we find something wrong, we check in. They order an x-ray, maybe need to see a specialist. Another check-in, maybe we refer you to one of our online behavioral health therapists. And you're doing this all mainly from your home. Over the course of the next few months, we're checking in, and you do have an urgent care need at 10 o'clock at night, someone will be available for you. And then the process starts again. In that way, we're able to start saying we can take care of people at scale and take care of their primary care needs online, automated, highly efficient, highly convenient, high quality, low cost. So, remember, we cannot solve our problems using the same thinking we use to create them. We aren't looking to replicate office visits online. We are using a lot of technologies to automate and scale that. And just like all the movies, a little magic can get you a long way. Thanks.
A
little Q&A?
I have some question.
I think there's a lot of things involved in this follow-up visits, anything get wrong, they're calling the doctor, someone is attending and calling back. There are biometrics involved, a lot of monitoring there involved. So how we can say it's a cost-saving, cost-effective?
So how's it going to be cost-saving if people need stuff? Well, this is where automation can come in. And part of this is also early detection and recognizing things, right? Because one of the problems that we have in our society is people don't see the doctor until it's too late, or until it's too far, right? Their diabetes, hypertension, these are silent diseases. By time many people recognize and go into the ER, et cetera, it's much more costly. So I'm not saying the day-to-day is necessarily going to be less expensive, although I would suggest it is. I would suggest that what we're doing is creating a new form of doctors, virtualists. In the years past, we had one doctor who took care of you in the ICU, the hospital, the office, maybe at home. We created intensivists to take care of you in the ICU. We created hospitalists. Now I'm suggesting that the primary care doctor today in the office is really going to become the complexologist of tomorrow. They're going to see those sicker, more complex people and take better care of them. And the virtualists will take care of the lighter weight routine folks, send people in only when needed. And the result is you start scaling correctly. We've over-democratized healthcare. Everyone gets a 15-minute office visit, whether you're a 22-year-old with a sinus infection or a 72-year-old with AFib, CHF, diabetes, hypertension, et cetera. And what we need to do is think like every other industry has done and say, for the people who are healthier, the vast majority of people who have routine issues, let's make that really lightweight, easy, automated. It's what they want, and it will be cheaper. And then the doctors in the office will actually have time to see the more complex people, so you win on both ends. The healthier people are going to get earlier detection, easier care for the basics. The complex people actually can get in to see the doctors and actually can get a 30 or 45-minute visit, because those complexologists will see less people, but they'll take care of the ones that really need to be seen and use their expertise. And the health system as a whole will save money. Hopefully the ER may suffer a little. Hopefully, if that's what we found with telehealth in general.
Okay, how about one last question?
So most of us, or a lot of us, come from an academic background, right? So we got the technology piece, we've got the business models coming together, we've got the policy, we have the minds to be able to do this. My question is, how do we actually train our med students, our nursing students, our people to not just be accepting of this, but to really embrace? Like, our structures are not built for that, and we need to evolve those structures.
Mm-hmm. Yeah, so I created a white paper on this because it comes up so commonly. How do we get doctors to accept and embrace this? One is, as you essentially suggested, we're scientists, academics, and a lot of training, is use metrics, use numbers. I actually showed, I remember my group, that look, we've lost a lot of patients already. They're going to urgent care, they're going outside the typical primary care just to get what they need. There are numbers out there that show, don't be scared of this, embrace it. If you're a healthcare system and you own a primary care group, it's a lost leader. You're losing money on that. And if we can come up and say, look, we are not trying to steal your primary care patients. If you have patients who have a great relationship, fantastic. But the truth is, that's maybe 50% of America. A large chunk of America do not have primary care doctors and don't have VSee access. What if we could help them do it at scale? And by the way, large healthcare system and doctors in academia, if there's real problems, if we find significant problems, we're going to send them to you anyway, which is what you want, which is why you support those folks. At the same time, how do we figure out compensation mechanisms to say, hey, if I'm helping out, support your primary care group, how do we financially align that in a variety of ways? And it depends on the situation in which you can do it. And then finally, I'd appeal to the emotion, which is saying, look, you're a primary care doctor. You're almost certainly booked, full, et cetera. We have a huge need. Let us work together to fulfill this need. That's why I got involved with this, because I think everybody in the country deserves great primary care, and they're not getting it today. The people we talk to, they might be in rural areas, but a lot of times they're in the city, and they don't have time. More and more of the patients who contact us from their cars. What is going on? They have so little time in their lives for their own health that they take the time from when they leave work to the time they're going home as a small fraction of time when they can even deal with their health. We have a peak in the morning, a peak right after work. It's a sad commentary, but it's something that we have to understand and think about, which is one reason why we're also looking to be multimodal, video, phone, asynchronous messaging, et cetera. We have to be able to take care of people in a lot of ways.
Great, thank you, sir.
Okay,
can I
thanks.
ask one quick question?
Yeah,
So
you got one more?
when do you expect MDLIVE will go IPO, I guess?
Oh, I can't answer that, of course.
How about,
listen, I think all the companies here are growing, which we love to see the growth, and there are lots of different opportunities for us.
How about American Well? Do you think they will stumble?
I can't comment on that. Get Roy here. No, it's an interesting. Obviously, Teladoc has had a phenomenal run with that, and it's one of the many opportunities that all the big telehealth companies have.
Great, thank you.
Okay, thanks.